medical loss ratio does for insurance companies, which is a bad incentive, is if you can keep 15 to 20% of the cost, what you really want to do then is get that cost higher and higher each year. So if I can get 15% on $1,000, next year I'm like, what if I get 15% on $10,000? That'll be better. So their incentive is to increase the cost.
Welcome to The Path to Wealth, the show about well-being, fulfillment, and financial freedom. And I'm your host, Hennche. Welcome back to the podcast. I'm your host, Hennche, and today I'm speaking with Real Dog Speaks. You'll find him on Twitter or X, and he advocates for patient-focused healthcare, addresses healthcare system complexities, exposes middlemen, and explores the future of medicine. Today, we'll delve into the healthcare system, financial planning for health and well-being, and strategies for ensuring financial health within your family. This has really been a journey for me, so I'm glad we finally have a professional who shines light on understanding of the medical complexities when it comes to billing as well as choosing the right care provider for your family. So welcome to the show, Doc. So
Sure.
Kind of taking a look at the medical landscape and the insurance landscape from a doctor's perspective.
Sure.
And, personally, I've just been through a series of surgeries, which was kind of my first big encounter with the US healthcare system, which was really interesting. And kind of given that the path to wealth is taking financial and well-being into one podcast, I think having somebody like yourself and getting the insights from a doctor's perspective is like, where is the insurance actually, taking advantage of us? And
Sure.
where is the medical system actually taking advantage of us?
Sure.
And where does that actually take away from the wealth of the American people?
Sure. No, those are great things. I think the biggest change that I've seen is in the 80s, you had the HMO model, the Health Maintenance Organization model. And with that, you had one price, one premium, and you had all your care taken care of. So you had a narrow network of physicians, narrow network of hospitals, but everything was taken care of. So people got used to it. They got used to, I pay my insurance. They'll cover everything. I don't have to worry about it. So it was very easy. And then unfortunately, as you could imagine, people started saying, well, I think I'll use a lot more of this service because it's one price anyway. I might as well get my money's worth. And lots of people did that. And then, of course, all the costs exploded and everybody goes, oh my gosh, this isn't going to work. So then they kind of slowly changed over time. And I think one of the big inflection points was 2009. And that's when the Affordable Care Act was passed. And the idea with Affordable Care is that would make healthcare much more affordable, hence the name, and much more accessible to people. They would have lots more access. It'd be very simple. But unfortunately, it didn't turn out that way. And one of the good ideas with the Affordable Care Act that I liked is something called the medical loss ratio. And the medical loss ratio is a rule that says that an insurance company must spend anywhere between 80 to 85% of the premium on patient care. So if they get $100 from you as a premium, $80 to $85 should in turn be spent on you at a minimum. So they really can't have administrative cost / profit of more than 15 to 20%. That sounds great. And everyone's like, that'll kind of rein in things and we'll get a good deal. Unfortunately, two things happened. One thing happened is you started having massive vertical integration. And what that means simply is you start adding things onto the health insurance company. So health insurance companies are run by very, very smart people, and they helped write the law. So they kind of had their workarounds in their head as this was going on. So for instance, United Health started a company called Optum, and Optum is now a huge part of United Health. And Optum has parts like Pharmacy Benefit Manager. So they are middlemen that get between the manufacturers of pharmaceuticals and the pharmacy and the patient. So they do things like they set the formulary. What medications are you allowed to get at what price? The problem with that is, with that control, is they started getting rebates from the manufacturer. So I would say to a company, listen, if you want to be on our formulary, if you want to be in a good position, you have to pay me some money. So they could get more money from more expensive medications. So all of a sudden, health costs started going up. The medication costs started going up dramatically. And patients didn't really even see this. They know they'd go to the pharmacy, and I remember when it was like $10, $20, or $30 for the different tiers. And it wasn't that bad in the beginning, but then all of a sudden that started to change. So that happened, and what that allowed the insurance company to do is overpay the pharmacy benefit manager for a medication. So if a medication really costs $10, if I say I'm going to pay $300 for it, then I can book that $300 as part of my medical loss ratio or my expense. Mm-hmm. But in reality, all I'm doing is I'm taking that profit and putting it in my other pocket because they own the PBM anyway. So all it did was shift a lot of cost. And then what happened from there, they started buying physician groups. They own ambulatory surgery centers. They own Change Healthcare, which is a payment processor. They own computer internet technology support that the government uses. The government uses Optum as a contractor. And they just went on and on. So right now there's more than 2,000 companies within Optum. It's huge. So these things just grew and grew and grew and grew, and the cost exploded. And so what became a simple idea, the medical loss ratio, became almost impossible really to calculate. You could just shift the cost. The other problem with that.
Is this where Mark Cuban's cost plus?
Cost plus drugs. 100%.
Yeah.
100%. So, and I'll get that one. The other thing that medical loss ratio does for insurance companies, which is a bad incentive, is if you can keep 15 to 20% of the cost, what you really want to do then is get that cost higher and higher each year. So if I can get 15% on $1,000, next year I'm like, what if I get 15% on $10,000? That'll be better. So their incentive is to increase the cost. So, but for the Mark Cuban thing, you're 100% right. So what Mark Cuban looked at was he said, there is so much padding with generic drugs that I could do is set up this very transparent thing. And if you go on his site right now, you can type in 3 or 4 letters of a drug and he'll tell you what it costs. He'll tell you if they carry about 3,000 drugs. And if they do, he'll tell you what the cost is for 30 days or 90 days in different strengths delivered to your home. So it's very easy to do. It takes about 2 minutes for an old guy like me who's not, I'm not Bill Gates, but I can figure it out very quickly. So his thing is saves tons of money. I use his service. One of my medications, I save 70%. That is 70% using my insurance. So the other thing, what happened with the Affordable Care Act or Obamacare, some people know it more like that, it mandated that you get prescription coverage. So that actually puts more money in the insurance company's pocket because now everybody has to have this insurance. So now they own the pharmacy benefit manager. You have to have an insurance. So in my case, I say, okay, what do I pay with insurance at the pharmacy? What do I pay with Mark Cuban's cost plus drugs? And I'm paying 70% less with Mark Cuban versus the insurance, in spite of the fact I have to pay for the insurance. And it makes no sense, the whole thing. But that's where Mark Cuban has done a great job. He also has expanded into manufacturing of drugs. So he has a manufacturing site, I believe, in Texas, either in Dallas or I think it is in Dallas. And he's manufactured some medications, epinephrine and norepinephrine, that hospitals use. So he's providing that at a very good price. The other issue with those type of medications is a lot of times the supply chain is challenged. So crucial medications that should be very plentiful are hard to get. And they're medications that we use in hospitals every day. Mm-hmm. So what he's doing with that is phenomenal. And he's also added a penicillin, benzathine penicillin, that we use for syphilis. And there's an increase in syphilis for pregnant patients, for babies, unfortunately, which is very sad. So he's really providing crucial links in the whole pharmacy supply chain. So he's done a great job with that. And he's just going to keep expanding. I know he wants to get into branded medications, name brand, and about 80% of the prescriptions, 80-90% are for generic. So that's what he's in right now.
Yeah.
And then there's something called specialty pharmacy. And specialty pharmacy, and I'm quoting Mark Cuban here, specialty pharmacy means expensive drugs. That's all it means. there's no uniform standard for what specialty pharmacy means. So right now, the big pharmacy benefit managers, and there's three huge ones that control about 80% of the market. They control about 70% of the spending on specialty pharmacy, and that's increasing quickly. And those are very, very expensive medications, and they're very, very profitable.
And this is what private equity started rolling up, where they were like, okay, we see that these are like unique niche medications that can have amazing profits, right?
Correct. So that's absolutely right. So private equity rolled up into that. Private equity also has bought a lot of hospitals and rolled those up. I don't know if you're familiar with the Steward Hospital system. So that's a hospital system that started in Massachusetts, started with a group of safety net hospitals in the Boston area, just outside of Boston. So by safety net, usually that really means that they're in a poorer part of town. They're taking care of people that are down on the luck.
Yeah, I read that story. I remember. Yep.
Yes. So anyway, so they went to, so there was a gentleman called Ralph De La Torre, who was a very, very successful, well-known cardiovascular surgeon in one of the Harvard hospitals. And he was kind of recruited to run these hospitals. And then, it's 4 or 6 hospitals in that original group. Then he met with a PE group, private equity. And then they did a lot of financial engineering where they basically went in and they loaded the system up with lots of debt. And then they also they had them sell all of the real estate. So not just the land that the hospital's on, but the building itself. So now the hospitals have no assets and they have to pay huge rent. So it's a big burden on them. And they expanded to numerous other states. And the Ralph De La Torre, who's the CEO of it, has 2 very expensive yachts. I believe they cost $55 million and a private jet. And, is paying himself $4 million a year. And they couldn't afford to pay the vendors, the suppliers of the hospitals. So it just a total disaster. Then they went through bankruptcy and they're kind of going through that process right now. But it really is harm to communities when this happens, with private equity, when they come in and they kind of strip and flip. They take the assets out, sell that. And that's how they make money in business, but it doesn't do well in the hospital. It destroys hospitals and communities. So that's kind of how that all played out.
It's interesting. This reminds me a little bit of it's like a documentary, Inside Job, from the financial crisis, where, there are those private equity firms or bankers who create financial architecture that gives them amazing profits, and then they don't have to pick up the liability when the assets start crumbling. It's like,
That's
okay,
true.
that year's banked, it's a done deal, and then
Right.
they've silver lined their pockets, but the actual community, the asset has crumbled and deteriorated.
Correct.
And people are like standing there and yeah.
No, and that's exactly what. And and maybe there's private equity that's done well in other healthcare situations. I'm not aware of that, but this one's been, unfortunately, a disaster. And it's been a disaster, for the patients, for the staff at the hospitals, for the physicians working there, the community at large. Because if you take those hospitals offline in Massachusetts, there's not enough capacity for all these patients. So everybody's very concerned about it. The governor is very concerned about it. And, supposedly they're not going to close the hospitals, and I hope they don't, because there's definite need there for them. But you also need enough money to run the hospitals in a safe manner. So that's the other part of it, too.
Let me ask you a question. So if I'm a patient in this current system, I find it incredibly hard to make the distinction of ownership. Like, for example, what happened to me, I had an accident. I came to the hospital. Once you're in the ER, it's very hard to do your due diligence. You need help in that moment.
Right.
And then being young, for me, it was kind of this situation, like, I never thought of myself sitting there and then having to contemplate whether I can agree or disagree to that surgery, and where can I, within a matter of hours, get enough due diligence and like information to make good judgment. Anyway, we didn't immediately opt for the surgery, but later I still had to kind of vet the system, vet the doctors, and
Sure.
I find it incredibly hard as a citizen to make sense of that and like actually find reliable information that allows me to make good judgment. One is, whether it's financially sound decision to go with that provider. And the other one, is this actually a capable provider who will give me excellent service?
You're 100% right. It's very difficult, especially in an emergency. If it's something elective, you have time, you can, compare the prices, you can, look at online reviews, you could talk to people in that field and get some idea of the quality of the physician. But you're right, in an ER, you're kind of stuck, and usually it's going to end up, if it's an emergency surgery, it's going to depend on who's on call.
Yeah.
And I've been on the other side when, I've come in and I'm an OBGYN, so the emergencies we would deal with in the emergency room are usually somebody having a miscarriage or an ectopic pregnancy. Those type of things are common. And I felt bad for the patient. I would walk in and they would look at me. They don't know who I am. The family doesn't know who I am. And I'm explaining things to them. And I'm like, you need surgery right now because you have a ruptured ectopic pregnancy. If you don't, you will die. And they look at me, they're like, I don't know who this guy is. Is he any good? And, they're just like scared. And I agree, it's terrible. And then they say, have you done this a lot? Do you know what you're doing? And what if I get another opinion? I'm like, you can't get another opinion. We're giving you blood right now. You're going to bleed to death. You cannot get another opinion. And I would just tell them, I'm like, I'm not arrogant, but I would tell them there's nobody in town who's going to do this better than me. Because I think they need to hear that. And now if it was something that I didn't feel comfortable doing, and there are those things, and there was time, then I would 100% be honest with people. People come in the emergency room sometimes with ovarian cancer. I'm not a cancer surgeon. They're usually not emergent. And I tell them, you know what? We don't have, the last hospital I worked at didn't have a cancer surgeon. I'm like, you know what? This would be terrible for you to get admitted here. We don't have a cancer surgeon. It doesn't make any sense. Here's the hospitals in town with a cancer surgeon. Here's the names of them. Here's what I can tell you. Here's the ones I know personally. And here's where I would go.
But
so
what
I
happens
definitely would do that.
if I don't have a doctor like you? Like at the end of the day, the doctors of a particular hospital also understand that this hospital is a business and that they are probably responsible to drive revenue as much as they're responsible for caring.
You know what? Not really. It's kind of funny because, most of my career I've been an independent physician. So, I work at the hospital, but I don't really have a direct business situation with the hospital relationship. So I don't really get paid. If I do the surgery at hospital A or hospital B, it doesn't really make any difference to me.
But if you don't make the surgery, that makes a difference to you.
That makes a difference for me. Correct.
So I don't do isn't that an incentive to do a surgery if it's like
not really? To me, it's not. Now, I'm not saying there isn't people that it is, but for me, I just look at it and say, okay, like going back to the patient with a cancer, I'm like, okay, her survival is going to be better with a cancer surgeon, a surgeon who did extra training.
Mm-hmm.
So my options are, I could do that surgery, but I know her survival isn't going to do as well. So I'm not going to take that on. Now, I've had the flip side where I tell patients, okay, you need to see this other surgeon because I'm not a cancer surgeon. And then they say, you know what? I know you. I don't want to go see that other person. I want you to do it. And then I just have to say, and the other person's in a different town and I don't want to go there. And, I just politely say, you know what? It doesn't make any sense for that. And I won't do it because I'm not going to do anything that's going to harm you because I have that, fiduciary responsibility. I have the responsibility ultimately to do what's right for you. So I don't look at the short. I kind of always looked at the long road versus the short road. So the short road would be, you're right. If I don't do that surgery, I'm going to lose that surgical fee. Mm-hmm. The long road is, that patient's going to talk to 10 people and they're going to talk to 10 people. They're going to say, well, this guy's a good guy because he said, listen, this other person is better for you. I'm going to get you set up with them. I'm going to get everything arranged and it's going to be seamless for you. You're going to see them in 2 days. We'll have everything sent there. People are like, this is great. People love that. So long term, I never worried about it. Mm-hmm. And every doctor's can be a little bit different, but I think most of them look like that. Most of us do not want to do something that we're really not the right person for. On the flip side is, and this gets back to your question, the patients don't know that. So if they see me for something that I'm very capable of, mm-hmm. and I just have to tell them that, and they really just have to trust me. They really don't have any other options at that point if it's an emergent case. If your appendix is going to rupture, your ectopic pregnancy is getting ready to explode, you're stuck. Your aneurysm of the abdominal aorta is rupturing. You have to go with that surgeon right there. There's no time. So I'd say at that point, and if you get brought in by the ambulance, they're going to bring you usually to a certain hospital. They're not going to give you a lot of options. So in those cases, you really don't have a lot of options to do, and you really can't do price transparency and make those other determinations. So that's the hard part, 100%. And I feel terrible for people in those. And I always try to calm people down and just explain to them and say, listen, this is pretty straightforward surgery. I've done it many times. I can easily do this. And I'd say by the time I talk to you, put all the notes in the computer, check all the labs, I could have done the surgery.
So I had 3 surgeries. 2 out of those, I think, went rather average in result. And then when I asked the surgeon in hindsight, like obviously they gave me all the confidence that you just mentioned. They said, we've done this multiple times, it's a routine intervention and all of that. But then the outcome was like kind of average, below average. And then I consulted other doctors about the outcome and they were like, well, that wasn't quite done the way it should be.
Oh, interesting. What kind of surgeries were those?
So one was a kyphoplasty and the other one was basically reconstructing my hand.
Gotcha.
And it was really interesting because I thought I have the input of multiple different doctors, but what I didn't realize is that, so I have German doctors as friends. So I consulted with them and they were like, kyphoplasty sounds about right for what you're going through. But I didn't define how my surgeon would do it. I didn't think that, so the Germans would have come in with 2 entry points and they would have been extremely specific about the filling itself, that it's timely. And then I spoke to another doctor here, unfortunately, a day after my surgery, who also said he would have done it that way. But the hospital I got treated at did it differently through a single entrance, and they were basically not able to fill it properly. And I kind of had to stop. And I saw it, but on the images, and I asked him about it, but he made it sound like, yeah, it went well. But then everybody else I showed it to said, no, it didn't go well.
That's unfortunate.
But the feeling is in there now. It's done. There's nothing you can do.
Our specialty is pretty straightforward. For a neck top, there's a couple different options of things you can do, and I would discuss that with them. Sometimes you can take out the pregnancy, leave the tube. Other times you end up having to take that tube out because it's been totally destroyed. And I would go through that with patients and give them options and it really kind of depends on if they want more children, the age, what the other tube looks like. And I would just go through that with them.
They have to make that decision right then and there?
You do. That's the hard part. But I try to give them some kind of background information. And I did tell them, a lot of it's going to depend on what I find when I get into the operating room. So, for instance, if somebody was very unstable and if the anesthesiologist says, you know what, you need to do a very quick surgery here because we need to get them out of the operating room and stabilize them, then you're going to say, you know what, I'm better off just to take that tube out. It's going to be quicker. We'll get the blood supply secured quick. So there's always nuances. And that I kind of tell them. I say, I have to get in there and see what it looks like. But it's a simpler thing than the surgery you had, though. There isn't that many options for, what I do for the emergencies. So usually it works pretty well. But it is hard because you do have to depend on that person and you don't know them. And I would say that, having been to Germany and known a few German folks, Germans are probably more precise than almost anybody in the world. So that's, so it doesn't surprise me that, the Germans are like, we would do it a little different way to be more precise. But I like the preciseness and I also like to be very precise myself. But like I said, it's a very hard thing. And that one, there really isn't a whole lot you can do. I think if it wasn't truly emergent and you could wait on the surgery, then you would have a little bit of time. And then I think the great thing is like if you have a source like your German doctor friends, that's perfect. Pull them in and say, hey, what would you do? And, what specifics? Even if they could talk to the doctor here would be great. Because sometimes if you're trying to get in between, it's hard for a layperson.
Yeah.
Where if they could talk to them, because they're always going to forget to tell you something. Or if they talk to the doc, it'll come up.
Yeah. Yeah. And this is also something I learned interacting with the doctors. They try to keep the language in such a way that it doesn't go over my head. And at the same time, doesn't scare me more. Like, because some people, it's like, for example, my mom, the more details I give her about the surgery, the more scared she gets.
That's true. There's a balance. You're right about that. I mean, there's some people are so frightened, and you try to minimize it a little bit, and other people don't seem to understand the risk, and you want to make sure they get it. So you do have to kind of fine tune your message a little bit.
Yeah. So if, let's say, for example, you were to get a surgery for anything, what would your approach be to make sure that it's financially sound decision, that doesn't destroy your financial future?
No, excellent question. So the first thing that I would do is find out, were they going to do the surgery at the site of surgery is very, very important. If it's something that can be done as an outpatient, I want to make sure that it's not a hospital outpatient department. So there's kind of two groupings. One is hospital outpatient department, and another one is a freestanding surgery center. And the difference is the hospital outpatient department gets to charge a very large facility fee. So that's where you get these huge fees for no reason. It's just kind of the way the law works. There's a very strong hospital lobby. They go to Congress and they cry in this Congress and the senators' shoulders, and they say, oh, we need all this extra money because we're there in the rural areas. We're taking care of poor people. And you know and I know, every time you go by a hospital, they're always doing a huge building project. And they always say, oh, we have no money. It's like, well, then why are you adding a 4-story addition? If I have no money, I don't build another house. But they always do that. So that's the first thing, is to find out. So if you find a surgeon you like, you say, where do you do your outpatient surgery at? Well, because more and more surgeries are outpatient. And so that's kind of the first part, is to make sure that they do it at the proper outpatient procedure site, rather. And if they do that, you're going to save lots of money. So that's very, very important. And then I would tell them you need a really good estimate of the total cost of the procedure. So you're going to need every dime of that procedure laid out. Now, one of the places that I really like the model for, there's a place called the Surgery Center of Oklahoma. And the Surgery Center of Oklahoma is they actually give you a cost online. So you could go on their website today.
Yeah.
And it gives you the cost of the surgeon, gives you the cost of the anesthesiology, and it gives you the cost of the facility. So all in one price. So you get one price, and the whole thing is in one price, which I love that.
Yeah, they literally advertise posting prices since 2009, Transparent Surgery Center of Oklahoma.
Yes, it's beautiful. And they've done a lot of interviews. They have raised their prices one time since 1997. That's it. So these guys are really good, and it's a wonderful system. So I really give them a lot of credit. So that's an example of a place that's really transparent and wonderful. And they put on there their infection rates as well.
Yeah, I saw that here, the lowest infection rates compared to the average of 2.6, and their infection rate is close to 0.0.
So, I mean, that's like the ultimate, but not everybody lives in Oklahoma or wants to go there. Now where that center is really good is if you have a self-funded plan, or if you don't have insurance and you're paying out of pocket, it's going to be much cheaper than anything you'll find anywhere else. So that part is really good. And about 90 million people have what's called a self-funded plan. So their employer essentially pays all the bills. So they have an insurance company. When the bills come through, the employer pays them. So for you're an employer, and if you come to me and say, you know what, I found this Oklahoma Surgery Center, and I'm just going to pick a round number. Say my surgery will be $10,000. They're all in. If I go to my hometown one, it'll be $20,000. I have a $2,000 deductible. Will you pay the whole thing? Because otherwise they're going to pay the rest of it. They're going to pay $18,000. So you could say, well, would you rather pay $10,000 or $18,000? So a lot of the companies will say, well, just pay the whole thing. You won't have any deductible.
Wait, I wasn't even aware of that. So in my case, my insurance is Cigna.
Sure.
And we are insured through an IT company, through my wife. And so I had an accident, and the IT company is paying the bills in this manner?
They may be, yeah. There's two options. They can be fully insured. And fully insured means that your company pays a premium to Cigna, and Cigna pays the bills.
Okay.
Or it could be they're self-funded, and if they're self-funded, then they pay the bills. And that's something it's always good to know with a plan which one they fall on. So usually a bigger company will do self-funded. And then it's interesting, the self-funded ones are regulated by the federal government under a law called ERISA. And the fully insured are covered by the states. So there's, so that's really important to know if there's an issue that comes up. Are we fully insured or is it self-funded? Because it's like totally different laws that apply.
This is so interesting. I've been insured with different companies. I had no idea there's even a distinction here.
And it's funny because what will happen is someone will live in the state and the state will pass a law and they'll say, and I'll just come up with something. They'll say, there's 0% copay for breast reconstruction after breast cancer. And the patient will say, that's great. I'm going to need this surgery. I won't have to pay anything. Then they find out that their employer is self-funded and they're regulated under federal law and none of those state laws apply to them. So it's always hard. Patients don't realize that.
Oh, man.
Yeah.
So I find this entire system, so from the beginning of our conversation to now, I feel one, incredibly naive about maybe how I approached some of this in my medical journey. But two is it almost feels like it's a maze by design, where you get so lost to it. You literally need to be a medical professional to understand the system.
It's very, very confusing. And the thing is, I just went on Medicare, and Medicare is more confusing than commercial insurance. There's more parts to it. And because everybody kind of says, well, maybe we should just have everybody go on Medicare. And it's kind of funny. None of the people saying that are on Medicare, and I was like, it's not a very easy, because you can do traditional Medicare, you can do Medicare Advantage. If you do Medicare Advantage, there's a plethora of companies. If you do traditional Medicare, most people get what's called a Medigap policy or a supplement. There's a number of those. And then you get a drug benefit. You can get Medicare Part D. And then they also have dental vision is separate. There's all these different parts. And most people end up using essentially a broker, and then they kind of talk to you, and then they help guide you through it because it's so complicated. And, there's so many different parts to it. And then the amount you have to pay depends on how much money you made 2 years prior to when you start on Medicare. And then if that changes, then you have to file a IRMA form to change that. I mean, just the complications go on and on and on. So that's more complicated than people think.
I find this quite wild, especially coming from Germany, so if you're with the government kind of insurance program, you really never worry about this at all. So, there's a percentage of your income that gets deducted. Regardless of what you earn, you will kind of get the same service. Sure. And you never actually see the hospital bills. You just give them your insurance card. You get to go to all the doctors you want. There's a little bit of a system and it takes some time. So you can't just walk in with the specialist all the time. But basically everything gets taken care of. And you never see the hospital bills. And it was only when I moved overseas, when I was facing like actual hospital bills and I saw the billing of it, which in Germany, you really only see if you get a private insurance, which means that you're a little bit more well off and you opt out of the state scheme and kind of pay for your own. But I find the US incredibly intransparent, and it's very hard to understand.
It really is. And the other thing that's interesting, when I was coming up, so like in the 80s, most of the physicians were private practice, they're independent. So kind of the thought was, boy, these physicians are driving the cost. They're like the big problem. We got to get these guys under control. Now, 80% of physicians are employed. So there's very little. If you're employed, you have no say-so about anything. Like if you go to an emergency room and if you have a bill for $10,000, you're there and they did some scans and they did some blood work, they gave you some IVs, they say, here's a $10,000 bill. The physician who saw you is, a lot of times they're just working on a contract and they get paid so much per hour. They don't see any of that. They might get paid, 150, I'll just pick a number, $175 an hour. So, and that's it. They do a 12-hour shift and they go home. That's it. So that, and everybody looks at them, they used to think, oh, that guy's getting $10,000 from me, but really you have nothing to do with it. And most of the bills are from the hospital and not from you. And
Yeah.
whatever you do, it doesn't really matter. They have their own thing going. So that's the part that's so confusing. But people used to think we control it. And to some degree, there's a few people think that, but now I think most people are getting that, these hospitals are huge. Usually they're part of a hospital system. They're hardly ever just a single hospital. And usually, like in my town, we have Baptist Hospital. They have a number of hospitals. Then you have Ascension has a number of hospitals. Usually it's not just one hospital. And usually they're part of a nationwide chain.
Yeah.
So that's the other thing. Like, I don't know in your area who are the big players, but
Lee Health is the biggest by
okay.
far. Yeah. And it's so interesting when I heard you speak about like building new buildings and stuff,
Yes.
going to the outpatient center. I'm like, yeah, I've seen all of that. They're literally under construction right now.
Yes.
They took me to the outpatient center for 2 surgeries, which has the hospital affiliation.
Yes.
um,
And they tell you they have no money. So, and a majority of the hospitals in the United States are nonprofit, which means they pay no taxes, and they actually charge more than a for-profit hospital, and they actually give less charity care. So before you had in the United States, before I think it was 63 or 64, 1963, 64, they came out with Medicare and Medicaid. Medicare was meant to cover everybody 65 and older, and Medicaid for people that were poor. So once that came around, there really weren't that many patients who didn't have any insurance.
yeah.
And then, now with the Affordable Care Act, that was supposed to get rid of all of those people. But in spite of that, you've got all these nonprofit hospitals there who, like I said, don't pay any taxes. But what they do, they want to break even. They don't want to show profit each year. So they pay their executives a huge amount. They have lots of executives, and they're always building something. And they say, oh, we're not making money. So it's very interesting.
Yeah, so to me from the outside, it really sounds like this is not a healthcare system. Like this is, it's not really about health in many cases. It's like when I look at some of the health issues that I see in the country, it almost feels like let's keep the population just sick enough so that they are recurring revenue in these
Sure.
schemes.
There isn't a lot of money for the hospitals if people are very healthy. You need people coming in the hospital. So usually inpatients are going to, oftentimes they're going to have cancer. They're going to have had a heart attack. They're in congestive heart failure. They have emphysema, those sorts of things. So you're right. If the people are very healthy, now being an OBGYN is a little different. People have babies, we want them to be healthy.
Yes.
And then, for the different surgeries, the gynecology surgery, usually we want them to be healthy as well. But definitely for the inpatients, they do have different incentives. And it's a huge business with so many middlemen that I will say this, up to this January, I didn't fully comprehend the amount of middlemen in healthcare because I was too busy taking care of patients.
Yeah.
And I didn't really comprehend how much money they take out of the system. It's huge. So that's and that's why it's going to be more and more important for patients to really advocate for themselves. Like I said, try to find out what's the best way, the most efficient way. And then they have to also advocate for themselves to make sure they're getting good care. And I use a direct patient care. My primary care is not through insurance. I just pay a gentleman so much a month. My wife and I go to him, but it's very easy. I can call him anytime. If I need a referral, he'll do it right away. He'll see me the same day if I have a problem.
Yeah, this is interesting because of the cost of care in the United States, this is how I do my overseas. Like I tend to either I go to Germany or India, and I just pay out of pocket, and the service just is differently because you don't have an insurance. It's very straightforward, and you can directly take advantage. And this really blew my mind. This is when I understood the discrepancy between the charges I've saw for, like, for example, my MRIs in the US or the CT scans. And then if I would do the same scan in India, which they use the same machines, they have the same machines. It's just that the circumstances around the levels of insurance, the billing and everything, and the people trained on reading those scans, their cut of everything is significantly different. So what I get billed here, like in the thousands, it costs me like $100 $50 over there, or an X-ray is like not even $50.
There's tremendous overhead. The other thing, which is kind of interesting, that is happening in Africa and I believe in Asia, they have a huge problem still with tuberculosis. And what they have set up, and it's fascinating, they've set up artificial intelligence program, and then they use a portable x-ray machine. So they can go in a village, they can get an x-ray, and then the artificial intelligence programs reads the x-rays and screens it for tuberculosis.
Instead of a doctor,
because they don't have the radiologist there anyway.
Yeah.
But then when they compare it to the radiologist, it was actually more accurate because they trained it on millions of x-rays.
Yeah.
So it was fascinating. So that cost got very, very low to screen. And then, so then you could screen for maybe $20. You could do the x-ray, the reading, and then you could do the testing for if they have tuberculosis then and find out what strain and how you would treat it. So it was really fascinating.
Yeah, I think this is actually where the future of healthcare is very exciting, because the kind of application that compute can do, and it starts with imaging work, but I also see it in wearables, like for example, like having an Aura ring or Whoop on that actually, like I saw when my father was going through cancer, I gave him a couple different wearables, and I saw his health decline in the metrics before the doctor said a word. Like I'm like, something is trending differently here.
Yeah.
And I think this is so cool because it's so affordable. It's like we can get into this way earlier now. And I think in a similar case, like with tuberculosis, in those cases, that the real way to help is to get in as early as possible. And I think that's where technology will make a tremendous difference, because imaging and everything is getting better and better and better, and we can get more and more granular and find things a lot earlier before they get out of hand.
Sure. No, I agree with that. I think that's very helpful. I think the other thing is, it's kind of interesting. They have some of these cancer tests, a blood test, and it picks up kind of fragments of cancers in the blood. But those are pretty early yet. So
but it's not like a PSA test, or?
No, those are kind of older. So PSA, and then PSA is for prostate, and CA-125 is for ovarian cancer. Those ones are more of an indirect test, so that's one of the problems with them. So they don't directly measure something from a cancer, where these newer tests actually gets fragments of the cancer DNA floating in the blood.
Oh, very interesting.
So that's phenomenal. The problem is it's so new, no one knows what does that mean. So if somebody, for instance, had, say, pancreatic cancer, you treat them, you look around, you say, we don't see any evidence of disease. We think we're fine. Now you do this blood test, you're like, oh, it's showing some fragments of cancer.
Okay, so
then what do you do? Do you do more treatment? Do you give them chemotherapy? Is that going to make a difference? Are you just going to make them miserable? That's the part we don't know yet.
Yeah, this is actually very interesting. Like, for example, the gut microbiome is a hot topic in health right now, and people are looking into it. And there are scans or tests rather, where you can determine what the gut microbiome is, but nobody knows what a good one actually looks like. It's like, okay, what should it be like? They're just like, okay, this is the kind of the footprint you have right now. I'm like, okay, what does it mean? Well, we have no idea.
No, you're 100% right. So it's going to be interesting times, but we need to kind of really standardize things, and that's always the hard part. And we found that in OB, because you could do blood tests at 10 to 12 weeks, and those tests screen for abnormalities in the babies. But you can also get some genetic results that are hard to interpret, and that's very tough for patients. So some of them were very straightforward. Other ones you're like, well, we're not sure what this means, and that's not very reassuring if you're pregnant.
Yeah, and I think this is the fine line. This is where also I think a lot of what I'm taking away from our conversation is we need to have agency and ownership in our health journey. We need to vet the doctors. We need to understand the process. We need to understand the treatment, but also we need to understand what information we can live in. Like, if we're very capable of dissecting information and taking on a test that could potentially lead to a finding that is not resolvable, can we psychologically take that, because
Correct.
not everybody will benefit from knowing there's possibly something, but the rest of the imaging doesn't show us anything, so we don't really know what to do with you.
Right. No, I agree 100%. And I spent a lot of time talking with patients before they got carrier screening. And the carrier screen is a really good example because, in the beginning, you do carrier screening for maybe half a dozen disabilities, things that usually were going to be universally fatal for the baby.
Yeah.
Now you can screen for probably, and I don't even know what the number is this second, let's say it's 400 diseases.
Yeah.
Well, they're not as good, the data, on probably 200 of those screenings. And there's all different variants of those disorders. And you don't always know what the effect is going to be. So I would sit down and talk to people and say, well, we have a couple different options. Before you do this, though, here's what I want you to think about. Exactly what you said. What are you going to do with the information? If you say, I'm not going to do anything, but I'm going to be so nervous the rest of the pregnancy, I won't sleep at night, then I'd say probably you shouldn't do it.
Yeah.
If you'd say, hey, you know what, I will act on this, then I'd say, okay, fine, do it. And other people go like, you know what, I don't know what I would do, but I'd be fine if there's some ambiguity. I'm like, okay, but I spent a couple visits with them. But I wouldn't just, some doctors are like, here, get this blood test done. And then have to talk if it goes bad. Where I would say, like, let's sit down, let's think about this through. Ideally, I'd like to see them, if they're saying, you know what, I'm going to try to get pregnant next year. And then I would say, okay, you could do the carrier screening now before you get pregnant. And this is what it means. I want you to think about it. That was the ideal, because then they could have a year to think about it, literally. Once you're pregnant, you have a limited time.
So in terms of, we were talking about kind of ownership and everything that one has to,
right.
that somebody basically really has to be on this for themselves. And where do we find more hospitals, for example, like the one in Oklahoma you pointed out? Like, is this something that we can find in every state? Is something we can find in Florida?
It's pretty limited, because I've looked at that. The same thing I started, looking on the internet. And I would say now, because the hard part is physicians are not allowed to own hospitals. There's a prohibition in the Affordable Care Act. So the Hospital Association, which I mentioned is very powerful, that lobby, they convinced Congress to say no physicians could own hospitals. Because Oklahoma Surgery Center is owned by physicians. And if you have, and I've worked in physician-owned centers, I've worked in ones that, the hospitals own. When you have hospital ownership, everything is different. The cases go through there much slower. It's much more inefficient. Hospitals love lots of rules, protocols. And physicians are just used to, like, let's just get this done. We'll do what we need to. Yeah, they're much more efficient. They're much more German. I will say this, okay? So I will say, the hospitals are just by nature, they have so many layers of people that aren't doing anything. But I would say if you go to Oklahoma Surgery Center, their website, they've got some great interviews there. And it's fascinating because they really do a great job of explaining the differences.
Yeah. So another takeaway that I'm having from this conversation, that basically healthcare cost is inflated on purpose because it means larger revenue can go into the pockets of those institutions.
Absolutely. Right? That's 100%. And that's how Congress wants it, because if I'm doing well in my private practice, I'm not going to give lots of money to Congress. I'm probably not going to give any money, and they're going to get lots and lots of money, which they call campaign contributions.
Yeah.
So it's not a bribe. A bribe is illegal. Okay. But you could do a campaign contribution. And, so if I'm a huge hospital system, if I'm Ascension, the largest Catholic hospital system in the country, I have lots of places, lots of hospitals, lots of money, so I'm going to hire the American Hospital Association to lobby on my behalf. They're going to hire the best lobbyists. They're going to give lots of love to the politicians. And not only that, the agencies that regulate the hospitals, they're going to give them lots of love. And then when the people get out of those agency jobs, they're going to go work for those companies. So the very people they're regulating, then they go work for them. Yeah, so it's very, very corrupt, extremely corrupt. And if I did the same thing in my practice, I would get arrested. So there's something called the anti-kickback statute. And if you look up anti-kickback for physicians, you get 10 years in prison. They will arrest you in a heartbeat. I'll have a SWAT team here, I'm gone. Okay. Now, pharmacy benefit managers get kickbacks every day. That's just how it is. And there's something
Yeah.
called group purchasing organizations, GPOs. They get kickbacks every day. So there's a movement in Congress to say, let's not have them get kickbacks. That's not a good thing. Politicians don't want to do it because they don't want to lose out on the gravy train. So there's so many incentives. So that's why if you can ask what the cash price is, if you essentially can get outside of that insurance system, you do better. That's the way. If you just say, you know what, if I can pay $500 for this scan. Now it's fascinating when you say, hey, why not take it a step further? Can you go international and get the same quality? That's a fascinating question. When you said you went to India or somewhere.
And the tricky part there is, so for example, when I found myself in the ICU with a broken spine, then you still need some level of care there for emergencies. But I think
You do.
for everything else,
You do.
I'm very much first overseas because it's much more manageable for me. It's much more transparent for me. I understand the cost better because it's just done maybe more like Oklahoma, where they're actually giving you transparent pricing up front,
Yeah.
and you know what you're getting into. And I think in the US it's a bit deceiving, and it's
It's totally
very
deceiving.
hard to comprehend.
It is. And people who are born here and live their whole life there, they have no idea either. It's very, very difficult. And I would say the ideal would be when I was a child, when I was growing up before the HMOs, you had insurance for catastrophic events.
Yeah.
So like your accident is a great example. You would have insurance for that. You would not have insurance to go to the doctor's office to get medications, to get tests done, to get labs done, because they were inexpensive. Because what happens is if patients have to pay the cost of something, you can't have it expensive or nobody's going to do it. If I open up a CT scanner and I say, I'm going to charge $100,000 for CT scans, I'm going to do 0 in a year. Nobody's going to me. They're going to say, this guy's crazy. But if I make it affordable, they do a good job, then I'll be busy. That's how it used to be. But then you got more and more corporations that, came into it. And now it's crazy. And it's interesting because people say, well, we should have government care. The government already pays for Medicare, Medicaid. They pay for over 50% of the care in the United States. And the large corporations are very embedded into the government. The politicians know what they want. The regulatory agencies know what they want. They're almost part of the government now. Like I said, Optum, a subsidiary of United Health, provides the IT services for a lot of the government, which is interesting because Change Healthcare got hacked this year.
Yeah.
And that's a part of them. And at the same time, they're providing services to the government for cybersecurity. So I'm like, okay, the Russians hacked you already. Why do I trust you for cybersecurity? They already beat you.
It sounds like the healthcare industrial complex.
It's very complex. It's very complex. I feel terrible for patients. In the old days, so if you kind of have, where I say this a lot, if you have a war on physicians, you really are having a war on patients because physicians naturally are the patient's ally because we work together. In the old days, you see me, I was obese, I would see your wife, and I'm looking out for her care. That's my only interest. I don't really care about the rest of it. I don't really care if the hospital makes money on her. It's not my problem. I don't care. My only issue is how do I get her what she needs? Mm-hmm. But if I'm employed by a hospital, and if I think there's a really good doctor, but he's not part of their system, they're not going to let me send you there. They're going to say, no, you have to send them to this hospital and this doctor. I'm like, well, this person's much better. Like, well, you can't do it. So that's where it starts falling apart.
Well, Doc, this has been very, very interesting and enlightening. I must say, it's even worse than I thought.
It is worse. I'm sorry about that, Hennche.
And I definitely have to go down the rabbit hole even more so here to make good judgment for the future of, I think, the health of my family.
Absolutely. And I think that's a good way of looking at it. And I would look at, do you like your primary care that you have? Do you have a good family doctor or internal medicine?
I'm actually just vetting that. Because we just moved from New York to Florida, and so I'm in the vetting process of that.
I would look to see if they have a direct patient care doctor there where you pay them so much a month. I would look at that as well and just, see if that's something that would work for you or not. Because I really like having that access. Because when I
Yeah.
moved here, I knew all the doctors. I was in Wisconsin for 25 years, and I moved down here 5 years ago. I knew every doctor in town. I could pick up the phone and I could have a patient seen. Our practice in a small town, my classmate in medical school was a general surgeon, and he was 2 floors above me. So
Mhm.
I would call him up. I'd say, "Hey, Ray, could you see this lady for me?" He's like, "Sure, send her out." And he would call me a month later. He's like, "Hey, I got this patient in my office. Can you see her?" And I would just say, "Oh, sure, send her right down." And we just work her in. Nobody would do that in Florida. They would
Yeah.
think I was crazy. But you could routinely do that. I could do that with cardiology, whoever I needed. And by doing the direct pay here, I can get that access again. I could call up somebody. Now, he can't get me in a specialist right away, but he also knows the specialist really well, and I don't. And that's very helpful, to vet those doctors for me. He's like, "Hey, this is the eye doctor I would recommend for you, or the cardiothoracic surgeon, or the cardiologist, or, on and on."
Maybe last question on that. How do I make
Sure.
sense of online reviews on doctors? Like, how do I actually go through that and find somebody who isn't just nice, but who's actually a good doctor? Because
Yeah,
it seems
I would
like the
say,
reviews are more based on kindness and niceness than on,
yes, I would say that the reviews, unfortunately, aren't going to be that helpful
yeah,
because there's 2 groups of doctors. There's a group who just say, "I don't even care about it." They'll have like 6 reviews, they'll have 2 bad ones. So they'll have like a low score. And there's nothing
yeah,
wrong with them. They just don't care. Then you get people who are like, "Okay, I'm going to be hip. I'm going to manage my reviews. I'm going to use a service. I'm going to get lots and lots and lots of reviews." So I'll have 200 Google reviews.
yeah,
I'll still the 2 bad ones, but now I have 198 that say I'm great. But you're right, they don't really mean anything because that guy's actively managing it. He picks who's going to do his reviews. And they do the reviews because he's like, "Oh, he's such a nice guy. He listened to me." But if it's a surgeon, you're like, "Well, is he good technically? Is he a great surgeon? What's his results?" And so I would say word of mouth is good. I would say if you could find a good primary care who's been here a while, that's a real good person to talk to, a good
mm,
resource for you.
and unaffiliated to the hospital.
Unaffiliated to the hospital. If you could find that, that's why I like the direct patient care because he's not affiliated with any hospital. And he knows all the hospitals. He grew up here.
Yeah.
And so I just use him and he tells me because he does, he just works for his patients. That's it. He doesn't work for an insurance company. He doesn't work for the hospitals. So he truly is independent.
Nice. Well, Doc, thank you so much for your time. This has been super
Absolutely.
interesting.
Absolutely. Yeah. If you have any questions, just DM me. And I hope I didn't make you feel worse than you did starting out.
So where can people connect with you on X or former Twitter, Real Dog Speaks?
Real Doc Speaks. Yeah.
Yeah.
Connect with me anytime.
Thank you for joining us at The Path to Wealth. We hope you enjoyed today's episode. Check out our upcoming guests and be sure to share it with all your friends and family that want to take their life to the next level of wealth.